Just to let you know that the webinar is likely to last just for the hour. If you'd like to pose questions to the audience, could you please use the chat feature at the bottom of the screen? I think that's set as a default to panelists only. So if you want to say hello to other people that are joining, you just need to adjust that. Those who are on Facebook, we're obviously streaming live on the Leukaemia Care and the Lymphoma Action Facebook pages. If you've got any questions that you'd like to offer to the panelists, please drop them in the discussion threads, and these will get to the panel. And if we've got time in the allotted hour, we will endeavour to answer your questions. If not, we will follow up afterwards and get these questions to you. I think on that note, everybody has got the information required at the moment. Again, thank you everybody for joining us in the 3 groups. I'm not sure how many are still with us at the moment, but I'm assuming that we're good to go. So at this stage, maybe I could take the opportunity to introduce you to our panelists. Our practicing GPs are Elaine Hampton and sorry, I've lost my screen at the moment. Tom Kneale from North Wales. Both have cancer interests. Elaine as a GP facilitator, involved in supporting GPs with learning from a cancer-specific aspect, and Tom is also a GP education lead in North Wales and also has a personal cancer interest. Our third GP on the panel is a retired GP, is my friend John Perkins. John is living with a chronic leukemia and retired from practice fairly recently. And of course, Stephen, I'm sure you could, would you please introduce yourselves and explain a little bit more of the webinar?
Yeah, I'm Stephen Scowcroft. I'm the Director of Operations and External Affairs at Lymphoma Action. So this is one of a series of webinars that we've done in conjunction with Leukaemia Care. So welcome to everybody, whether you're a person affected by leukemia or lymphoma. We've got, thanks for your interest in sending in some questions in advance. We've also, we'll see what we can do to take some of the questions that you post into the chat as well. But I'm looking forward to a good discussion.
Thanks, Stephen, and thank you everybody for giving your time this evening. I think maybe we should just put things a little bit in context as why we're meeting. I think if we look at the blood cancer group of patients, the majority group are in the clinically extremely vulnerable group. We've been isolated for quite some time, and we need to also look at where are the different touch points that we would normally engage with our clinical community and difficulties we're having at that purpose, difficulties we're having in practice. So from a point of view of what we'd like to look at, Stephen, could I just ask you to take over for a moment? At the moment, I've just lost a few things on my screen. Apologies.
Yeah, so I think, as we said, one of the things that we're not going to be doing is discussing any specifics around the vaccine. We recognise that it's a very hot topic at the moment, but it's quite early days, and there aren't really necessarily any further answers to questions, and it's actually something that we're doing as our next topic of for the webinar coming soon. So more information about that into the early new year in January, when there will have a bit more time. But yes, so today we'll move on to the kind of first questions first, but just putting it into context. So we know that there are more people living with comorbidities alongside their leukemia or their lymphoma. That's another way of saying that they've got other disease areas or other things that might be affecting their health alongside their leukemia or lymphoma. But also, as things are developing with particularly more the chronic leukemias or the chronic blood cancers in general, it is akin to a lifelong condition. So people are living with their their particular type of lymphoma or leukemia, and often that brings other health impacts as well. So the main message today, and obviously our panels will be reinforcing this, is to encourage you to continue to go to your GPs about those things, as well as some of that is going to be monitored in the community as well.
I was going
anything to add to that, Nick?
I was just going to say, I think one of the points is I can also talk myself from a point of view as a clinically extremely vulnerable patient, and as blood cancer patients, we may in the main be more familiar with talking to our secondary care for disease-related issues. But I think what's become more apparent during my own journey and is that as blood cancer patients, we are perhaps a little bit more dependent on the support of our GPs to manage our general health within the community, and at certain points are likely to need a little bit more support. And I think at the moment in the COVID environment, there's less likelihood of in-person opportunities with secondary care. So, we're being pushed a little bit more towards our primary care and our GPs for monitoring in the community, blood tests, things of that nature. Yeah. And there's always been a little bit of a communication and an understanding issue. I'm trying to reflect back, as John brought this up earlier, was, at diagnosis is understanding who to talk to and where to get what support. So I think one of the key things in this session, before we actually look at how service is delivered, is looking at different touch points, which you're going to raise about how primary care and GPs can support blood cancer patients in primary care away from their specialists.
So that's a good point to start. So I was just going to ask Elaine if we can start with you. So generally, what can GPs do to support patients, kind of irrespective of the current climate we find ourselves in and the impact of COVID, but in normal times, or kind of how do people generally, what can GPs do to generally support patients?
Well, I mean, I think it's basically all of their healthcare that isn't involved directly in their treatment of, and follow and monitoring of their actual cancer. So I was going to say, so we're still there when they've got all the other, if they have their cough or cold or whatever, they need the sick note, they're struggling with anxiety and depression, which is quite common when you've got a cancer and things, as well as being a referral point if needed for referral onto people like dietitians and occupational therapy for help, if they're struggling at home and things like that. So.
Oh, thanks. And obviously, often the first touch point of that is around an initial diagnosis. Yeah. Again, that's not something that we're going to be focusing on too much. I think we've got other webinars, or we've had other webinars that have touched on kind of the challenges around diagnosis, and particularly with that from a GP's point of view. But yeah, you mentioned a couple of things there. So either during treatment, those are additional things, or particularly for people who are active monitoring. But I think it's also worth saying there is, GPs are a good point of source for support for the wider family as well, friends, family, people who are supporting a person with a diagnosis as well. Is that right?
Yeah. Now, I mean, as I say, sometimes it is about us sort of being the point to signpost people to other services that they might need and need to access and things, to make their lives actually better. Because often secondary care aren't necessarily they're focused on the disease itself rather than on the whole person as such, and the other things they might be struggling with. So, I mean, a lot of patients with cancer and things are often struggling with financial problems and things. And although I have no knowledge of how to access to actually, what benefits are available and all this sort of thing, I can actually signpost people in the right direction to where they can access all the help and advice they need, basically.
Yeah, okay. So, no, thanks for that.
Sometimes that's just causing lots of anxiety and worry, and it's just, if we can actually make the life a lot better from that point of view. And as I say, a lot of anxieties and depression and things are quite common.
And that could be at any stage of that, whether it's around diagnosis or going through treatment or kind of post-treatment and getting back to living as normal a kind of a life as possible post-treatment, and also possibly around the impact of other things might have, like bereavement or possibly end-of-life support as well. You know, again, I think, as you're saying there, the GP is the place that people keep coming back to access some of those services, and again, that might not be something that's people think about as the first point of call. So that's a good message to reinforce.
Now, one of the big places where people feel a bit abandoned, I know because I've been told this by patients, is when they come to the end of active treatment. They can feel all of a sudden they've been going to the hospital every 3 weeks or something, and all of a sudden they're told, oh right, we'll see you for follow-up in 3 months, and they can feel a bit abandoned. And that can be a point where they might need the GP more and things. The problem for us, I mean, it's been suggested we should be contacting people at that point, but often we aren't actually aware of the fact that they've come to the end of their active treatment, possibly for a considerable amount of time after it's actually happened. So, you know, but we're always, well, you know, we will always do our best to talk to people if they contact us. So. Yeah.
Okay, thanks. Nick, did you have anything to add to that?
Well, I was going to actually ask Tom for a bit of a perspective there. And I think one of the other groups that weren't mentioned was obviously those that might be diagnosed early in their pathway or on watch and wait, who might be asked to communicate, well, be more likely to be talking to a GP on a regular basis for other ailments. Might not see their consultants and their clinicians in secondary care for some time, but I'm just wondering. I suppose from that point of view, you know, Tom, have you got anything to add from a practice point of view about how you're looking after your patients in your community with cancer, blood cancer specifically? Are you on mute, Tom? There you go.
I mean, we touched on initial diagnosis just briefly, and I think sometimes...
Your volume's quite low at the moment, Tom. I don't know why that is.
Can you hear me now?
Yes.
I'll lean a bit closer. I think we mentioned just initially, and I think one of the key things is you know, we do always want to be spoken to and contacted, and sometimes we can clarify things a little bit, because particularly at the beginning, you might be a bit shocked or might meet a lot of different professionals, and things might not be very clear in your mind, and sometimes just having that space just to chat with the GP and say, well, I wasn't sure about this, and this, we might not be able to answer everything at all, but we might be able just to help you clarify a few points or things that are worrying you, and I think that's quite important just at the beginning when you're seeing a lot of different specialists, and you're not sure what's quite what's happening, or if you're a bit confused. So I think that's probably a good point of contact. And just as Elaine said, because you've got a cancer diagnosis doesn't mean that you're also not going to have a lot of other perhaps other health issues which your GP is dealing with, and they might be put in the background a little bit because you've got this big diagnosis to deal with and manage, but they're still ticking away, and it's really important that you still contact us and spend some time managing those other conditions if you have them, really. But the key message is that we really do want to hear from you, and we want to be able to answer your questions if you've got them to ask, really.
Thanks, Tom. That's really helpful, and I think we'll come on to fairly shortly about how we're engaging with GPs at the moment and how to do that in the best way.
Yeah,
John, you're with us there, and I'm just wondering. Obviously, you wear two hats as a GP, a retired GP yourself, and a patient living with a chronic leukemia, and you've been through a lot of different stages in that journey. Are you able to reflect from two sides, sort of your own experience of supporting patients living with blood cancers and cancers, and also as a patient now, you know, from the other side of the fence, having to live with the condition and understanding who to contact, when to contact, and how to get your support. What are your thoughts?
Am I muted? No, I'm not. I'm live. Yeah, I mean, I found a lump which was referred for a biopsy, and that was 10 o'clock in the morning. By 4 o'clock in the afternoon, I had my diagnosis of CLL. I went from my morning surgery to the appointment at the hospital. I'd saw a few patients, and was catapulted, if you like, into patient mode very abruptly. I never went back to work. I couldn't. I was shocked, if you like. I had to deal with this diagnosis. And then looking back, of course, the signs of CLL were there probably 3 or 4 years, and I very skillfully, I think, managed to deny them, ignore them. I mean, it was of no great consequence in the long term, but clearly I've also had FCR, and once I was treated in remission, and I felt completely different to what I felt for several years. So as a GP, I was getting older, and I thought I was just getting tired and worn out, but actually I was ill, and it was creeping upon me. I think as a point about GPs, I think Tom alluded to this, that I'm very lucky to have a very good relationship with the hematologist and my own GP. But CLL takes such a big part of one's life and consciousness and focus, and it's complex disease and fluid and heterogeneous and all the rest of it. But the other little bits of one's numbers and so on, I mean, my GP spotted that one of my blood cell sizes was changing, and I hadn't noticed it, and the hematologist hadn't noticed it. It was it turned out that I had a very high iron level, and it was a fortuitous diagnosis spotted by my GP, who did my B12, folate, and ferritin levels, and found out that I had hemochromatosis as well, which, if it had not been for CLL, I would not have been diagnosed, and probably would have got me later in my life. So for me, it just epitomized the importance of the GP watching my back, if you like, so I can worry about being a medically qualified patient and being super neurotic about infections and neutropenia and all the rest of it, while the GP actually, I mean, you know, I applauded him. I was shocked how good he was at picking up these small details. So that's just an example, I think, of the role of GPs, keeping an eye on us, watching our six, watching our back, if you like. And it's something I try and reinforce whenever I have the opportunity.
John, thanks. That's really hit the mark there, and just reiterated why our contact with GPs is so important. So hopefully we can move on a little bit now and talk a little bit more about accessing our GPs, and I'll hand it over to Stephen again.
I was just going to touch, because I had a couple of quick comments in there, but I think to reinforce the messages that some people are saying about should they raise issues with their GPs if they're currently on watch and wait and they're not sure if it's kind of their lymphoma or CLL or leukemia or other perhaps kind of co-conditions. It might be menopause in women or other kind of conditions, heart or diabetes that might be having. Should they raise those issues with the GP? I think generally the message is yes, kind of if you're unsure, ask your GP. That's what they're there for. Hopefully you're kind of, yes, you've all reinforced that as well. I think we'll kind of move on now to specifically more around some of the challenges around COVID. So, we know that since we've been in lockdown and come out of lockdown and then had tiers, etc., there have been challenges and different messages over the past almost 9 months now. But I think it's worth really focusing, what are some of the challenges facing GPs right now, and how are you kind of dealing with those in order to ensure that people can access GPs when they need to, but kind of are kept safe, or at least managing people's anxieties about whether they should come in or not. Perhaps Elaine, you can start off with giving some of your experiences as how that has changed over the last couple of months.
Yeah, it is really difficult because of COVID, and therefore the need to reduce the risk of patients actually giving us and our staff and each other COVID within the practice, and vice versa. We're trying to minimize face-to-face contact, but that means we have to, usually we telephone triage everybody to do a risk assessment, whether or not it's actually worth the risk of COVID or versus the risk of not seeing somebody face-to-face. It can be quite challenging, and also trying to pick up on the nuances of this patient's actually very anxious, and then we're not going to be able to allay their anxieties without actually seeing them face to face, because that's actually really important as well. Even if we think we can handle it, we can actually sort it out on the phone. Sometimes that's not sufficient for the patient, and they need the actual they actually do need to be seen face to face, but despite the risks. But we have to be so mindful that we don't want to be putting ourselves and others at risk because of that. So I certainly find it's just an extra layer of risk assessment on top of my normal consultations, and the difficulty of dealing with things on the telephone initially and weighing up the pros and cons of seeing people and things. So it is about not just protecting me, but protecting the staff in the surgery and the other patients as well, potentially. And it's quite difficult, and we actually do need patients to actually tell us if they're not happy, because sometimes we don't always pick it up if it's very subtly done.
And I think if you're worried, it's really important that you mention it, as Elaine was saying. And there are lots of different ways of doing things now, very different from how things were traditionally, where you phoned up and booked a GP appointment and then turned up and went to see them. Whereas now a lot of surgeries are dealing with things on video. Face-to-face consultations might sometimes be done if you're particularly worried. Occasionally, it's not unusual if it's just something which specifically needs checking. We might even come out and see you in the car sometimes. All surgeries do things slightly different, but from my experience, we tend to have a different room where we see people, which we clean down afterwards, and the flow of patients, the footfall through surgeries is much smaller. So my surgery is probably quite big, with 10 or 11,000 patients, but we're only having 6 patients in at any one time to our waiting room, and there's usually much less than that. And everyone before they come down will be screened with 3 questions about temperature, a cough, and any change in smell or taste. So it's really important to realise that all surgery is doing as much and as best they can to reduce any chance of coming across COVID within the surgery. And I often say to people, look, coming to see me is much safer than going to Tesco's. It's really important that people try to feel as comfortable as they can. And if they don't feel comfortable, really let us know, so that we can try and make it as feasible as we can to see you in a way which is appropriate and makes you feel okay about doing that.
And is there, I guess, again, one of the questions of that, is there how can people who are affected by cancer, are they prioritized in any way, or how can they feel that they can also access their GP when they need to? Because obviously they're clinically extremely vulnerable.
Absolutely.
And how do you address that?
So it's important sometimes just to don't be afraid of perhaps even just letting the receptionist know and saying, look, this is what's happening. Most GPs have a flagging up system, so often there's a pop-up which, when they open their notes, it might not immediately come up. Again, there's lots of different systems which people use when you're just on the booking screen, but sometimes if you go into the main notes, then it would pop up saying this person is on active treatment or had active treatment for cancer, and that just gives the receptionist a bit of a warning. And then sometimes a conversation happens, well, do you want to come down early on in the day where there's not going to have been any patients through the surgery, or late on in the day, and things can be a little bit more tailored to to suit you, and again even more minimize that risk, if that makes sense. So, but the important thing is not being afraid to let the receptionist know, or feel that should be a barrier to access, if that makes sense.
Yeah, so I think the message there is about perseverance. Kind of, in some cases, you might need to keep asking, and just not being afraid to ask those questions.
Don't be afraid to ask, and don't be afraid to let us know, because we want to do everything we can to help, really, and that's really important. And so do the receptionists. They're often busy, but that's their job, really. So just don't be afraid.
Yeah, and on that, obviously, as part of certain types of leukemia or lymphoma, need to have regular blood tests as well, as part of prior to perhaps going into hospital as well for a checkup, or they're doing that as being managed in the community. Has anything kind of challenges happened around that, or how, in your example, obviously it's going to be slightly different for every kind of area around the country, but how are you kind of continuing access to those blood tests?
From my perspective, it's done in a few different ways. So there are blood tests which are done within the practice, which can perhaps be a little bit more bespoke, if that's, i.e. you can book it perhaps a slot, which again, for example, first thing, if you were very worried about footfall through the practice. They're also done in the community hospital, and again, sometimes they're done in the car, in the community hospital or within the GP surgery, and then also we have district nurses who might go out to people's houses as well, depending on the situation and where they are with treatment. But we're a very rural practice, so that's something that we have to make use of. I don't know if there's anything different you're doing, Elaine.
No, I mean, we had problems earlier on in the COVID where a lot of the community hospital phlebotomy appointments went and were stopped altogether, and people had to come into the practice, or have bloods done remotely. It has improved a little bit, but it's not fully back on from what I can tell. But then that's possibly safe for people coming into the practice. But again, it is a challenge for us with trying to get with capacity, basically just the number of people needing to be seen, and it is a lot. The more people actually coming into the surgery, we have to allow more time than we did pre-COVID, because of all the extra precautions we have to take with the PPE and cleaning afterward and stuff like that. So so we just can't get the numbers coming through that we used to. And also the distancing. We don't actually want, even if they're not coming into the waiting room, we don't want like 20 people stood outside the surgery either, because maintaining social distancing isn't going to happen then.
And perhaps maybe that means that you maybe have to think ahead slightly more than you would do before, because certainly in the community hospital there was about a 50% reduction in the amount of phlebotomy they could do in one day, just because of social distancing and having almost a one in, one out. So therefore, if you know you've got blood tests coming, it probably may be sensible to book it further, or think about it further ahead, if that makes sense. Okay,
I was going to hand over on to Nick. So we just touched on there a couple of, instead of coming in face to face, and a lot more have been happening remotely, either through telephone or through video appointments as well. We've got a couple of questions, Nick, haven't we, around getting the most out of those?
Yeah, I was just going to ask, before leading on to that, something cropped up that for me actually that you might be able to help. When we're looking at elements of reduced need for visits to the surgery themselves, as well as blood tests, you know, the community have been kind of in lockdown for quite some time, so regular monitoring of, for example, blood pressure if we're on meds, things of that nature. And I had a call the other day from the GP asking me if I would visit a month after I'd gone down for bloods, that I obviously had to go down for a blood pressure check before my renewal of meds, you know, my medication prescription would be renewed. And at that time, the GP, you know, when I explained I was a little bit reluctant to, with current infection rates, having just bit the bullet as patients do and gone down for my bloods, I was asked about, you know, do I have my own blood pressure monitor? I was going to ask, are there any other, your views on the kind of tools and things that people can also make sure that they have in the home setting that can help with your own consultations and managing patients in the community unable to visit you? Before I visit the other questions, I just wonder if you've got any thoughts about those kind of things. Elaine.
Yeah, I mean, a blood pressure monitor is really helpful. And I must say, I've been asking a lot more people, do you by any chance have access to your own monitor? But thermometers are the other one that's really, really useful too. And for people that have breathing problems, something called a pulse oximeter, which means it's just stick it on the finger to check what their oxygen levels are. I mean, I wouldn't recommend that for everybody, but people that do have underlying breathing problems such as COPD or asthma and things, it can be useful for them to have something like that at home as well. Yeah, but as I say, it always shocks me how many people don't have a thermometer in the house and things, because it can be really, really useful, especially at the moment with the COVID as well. And being able to find out if somebody's got a temperature or not is really helpful before they actually attend. So have you got any other suggestions, Tom?
No, I think they're all worthwhile investments, and I think they've come down in price quite a bit now. Most of the reasonable ones are not hugely expensive, but you'll find you get quite a few years worth of use out of them, really. On the COVID side of things, we are occasionally loaning people pulse oximeters to keep an eye on that, and obviously I don't want people to worry a lot about things like that, but again, that's why perhaps pulse oximeters are sometimes useful. Some GP surgeries might loan out BP machines as long as you bring them back, but and again, they're safe because they can simply be wiped down with a wipe which got Actichlor in it, and then that left to dry, and then that would be a very safe option really if people are loaning them out. Yeah.
Can be the advantage of people coming into the surgery where to have the bloods as well, because we can encourage our healthcare assistants and things to check people's blood pressure and weight and things while they're in anyway, so it decreases the chance of us having to get them to come back.
I guess that's an important message, isn't it, at this time, is perhaps thinking about other things that might need doing, so that you're not having to make repeat visits, isn't it? Really?
Mm.
Thanks, Tom and Elaine. Just before, whilst we're on the thread of remote, I just wondered, John, as a patient yourself, avoiding contact as much as possible, being somebody very aware of your immune compromise, have you got anything to add in terms of practices?
Am I allowed to confess here?
Well, don't go too far, because I know how far you go, because as a GP you maybe go a little bit further.
Well, I will admit that I take my own blood, basically. My wife's a nurse, and it works very well. It saves a trip to the surgery, and stops clogging the surgery up, and I just drop the blood in, and I go and have venesection for my iron, so the blood pressures and so forth are taken then. I'm just mindful how busy the GPs are, and I do my very best to try and keep myself well and out of. I mean, fortunately, I don't have any other comorbidities, so I'm not being called up all the time. But I try not to fall over and graze my knees, so I end up, having to be stitched up or something. And I have email contact with my GP, which I use judiciously. And I think it suits us both, and he can answer it whenever he wants. If it's urgent, obviously I would call, but so far I haven't. So, knowing how GPs work, imagining how it must be, having retired now 4 years, and having done quite a lot of telephone triage in my time out of hours and so forth, I can only imagine the pressures you guys are under. So I just do my bit to keep my head down and behave myself.
Thanks, John. Mindful of the topic of remote consultations. Obviously, this patients are we're still visiting in person. So I'm just wondering if we could sort of follow on from this, the discussions about preparing yourselves that Tom you raised, maybe a little bit more time to prepare to make the appointments. But from the other angle, with the majority of connections now being by telephone or virtually, Have you, Elaine, if I could ask you first, have you got any tips to help patients prepare for their consultations and make the best, and that's in person in the current climate, and also most importantly, how to make the best from the telephone consultations engagement with you?
I think preparation, as you say, in itself is good. Actually think about why are you asking for the consultation. And if you've got a set of symptoms, it's a really good idea to write some notes as well. I mean, I know I've had patients when they came in for face-to-face consultations would sometimes bring me a list in, and sometimes that's really helpful for them to jog their own memories and things, and then you can expand on things. But also if there's particular things that you want to ask or know, something you're particularly worried about as well, write things like that down too, to make sure that so that you don't get off the phone and discover that you've not actually asked the question you really wanted to know the answer to as well. And also the other thing can be that if you've got several things you want to talk about, it might be worth writing lists, but also explaining that you've got several things, but starting with the most important things first. Because I should think Tom's had this where you have somebody comes in to talk about their sore toe, and then on the way out they go, oh well, while I'm here, and they talk about their terrible chest pain they've been getting and things. So they're just going out the door and you've got more. And the same thing on the telephone, what we want to do is talk about what they really most want to talk about first, rather than actually leave it to the end. So as I say, it can be good for people to think about what they want to ask about and actually put it in an actual proper, actually prioritize it a little bit as well, because we do. I think one of the things with telephone consultations is people aren't always aware. In face-to-face ones, we were aware of the fact that they knew there was like 10 people sitting out in the waiting room. On the telephone, people aren't as aware of all the other people that are actually waiting for their phone call as well. So. Trying to use the time as well as possible, really, basically.
Yeah, I agree. And I think we lose those non-verbal clues on the telephone, which we're so used to getting, seeing that people look worried or upset. We might not see that on the phone. So if you are feeling like that, then do let us know, or because we might not pick up as easily on the phone. And equally, just as Elaine said, you might not be able to see that we're pulling our hair out and running around really busy as well. So I guess that might not be picked up. But the main thing is perhaps having a quiet place to do the phone consult, or thinking if the doctor's going to be ringing you, how can I get to a quiet place if it's not a very specific time slot, and having that list there in your head or written down about what the thing that you're most concerned about and need addressing through that consultation, just as Elaine said.
Yeah, because I was going to say one of the other things is if you're not going to be available between certain times or something, actually letting us, the reception know, or if you're doing an e-consult, letting us know in that, so we can actually ring you at a better time. Because one of the things, like the other morning, I spent a huge amount of time ringing people who, and it took nearly an hour before I actually managed to speak to somebody. And actually it's actually quite time consuming actually preparing to ring somebody, because I always like to look at the notes and see what the reason is for me to be ringing and things, and then they don't answer the telephone. Can be a little bit frustrating. And as I say, we can waste a huge amount of time doing that. So as I say, if there are going to be times when you're not available, let us know in advance, and then we can make sure we don't ring you at those times. So
yeah, and to add to that also, I think because it's a phone call, it probably will take just as much time as it would do to have a normal appointment, really. And I found initially at the beginning of COVID, when I had lots of phone calls, I thought, oh, I'll be whizzing through my surgeries, but it just hasn't been the case. It's just as long, if not sometimes a little bit longer, and sometimes a little bit more complicated to sort things out. So perhaps just bear that in mind, that sometimes things might just take as long or a bit longer.
Thanks, Tom. And any thoughts on? Oh, sorry, did I cut somebody off there?
So it was me. I was just going to have a we've had a couple of questions that have come through from Zoom or from Facebook as well, particularly around things like people on a particular type of treatment or people with CLL potentially being at a bit more risk of skin cancer. And is that something that they should go to their GP about? And if so, if it's kind of a telephone conversation or a video, how can they kind of get them best out of that to try to get across some of those particular symptoms, which you know is easy to show in when it's face to face, but not so easy to kind of describe on the phone or maybe taking photos or whatever. So perhaps we can kind of explore that a bit more. How do people kind of ensure that they're getting that reviewed with their GP or requesting an appointment, and also how do they kind of get the best out of that kind of approach through the consultation?
Absolutely, and for that matter as well, the non-specific symptoms, you know, the ones that can't be seen, you know, how do you explain those in a remote telephone call? How you know, rather than normally you would lay down on the bed and be, you know, obviously be inspected during the consultation.
So perhaps Elaine can start with that, her thoughts.
Well, if you're worried about a skin problem, actually, ideally, yeah, if you can send a photograph. Most practices now either have something called e-consult, and you can attach a photo to, or you can send an email with a photograph attached, which can be a really good starting point. If we're struggling, then we might need to see somebody face to face, but we can actually tell quite a lot very often. I mean, the quality of photographs these days on modern phones and what have you is actually really, really good. So that really does help. So, but as I say, with the non-specific symptoms, I think again, you know, write them down, then you can actually put them to us quite much more easily than if you're trying to think of them off the top of your head as well. So, and then we can ask more questions, and if need be, we will then, and if need be, decide it necessary, we can see people face to face. But as I say, skin lesions, ideally, if you can send a photograph, that's great.
Okay, thanks for that. We've had a couple of responses to some of that you mentioned about the home monitoring devices, Nick, and the GPs kind of gave their experiences. Are they, in your experience, as accurate as the GP ones? And what about things like wearable technology like Fitbits or other type of things like that? Are you seeing that being able to kind of monitor people's health and then them talking to you about what their Fitbit has told you, or kind of sharing some of that data? What's your experiences of both of those things?
So I think the usual BP monitors which you buy, like someone mentioned on Run, are very good. They can be calibrated with GP's equipment if needed, and sometimes we do that for people. I think guidelines suggest that people can now, the NICE guidelines for monitoring or diagnosing BP will ask people to do a series of home readings now, so we're quite comfortable now with that for being used at home, and most machines of an average price are pretty good, so that's okay. I think Fitbits can give people an idea if they've got problems with their pulses, but they're not a specific diagnostic tool. So it might pick something up which we can then have a discussion further on and maybe arrange another test, but we wouldn't necessarily advise people using them to specifically diagnose something. So they have, and I've found in my clinical experience, someone's come in and said, I've noticed my pulse is racing up at this on my Fitbit, what's wrong? And then we do a few further checks and find something wrong, but we wouldn't perhaps do the opposite and use it in a diagnostic setting.
That's a good point. Thanks for that.
I've got one question, Stephen, that I was looking at.
Yeah, go ahead.
I touched on this earlier on service delivery and engaging with the practice. And it was more from a point of view of awareness of other members in the practice other than GPs, practice nurses, nurse practitioners, what their roles are in engaging with patients, and you know, what can they also do as well to help patients? Are you able to share a little bit more about that, Elaine? I guess that also comes down to the perseverance question as well. You know, when the message we're getting at the moment is, you know, being able to talk to somebody. It was never easy talking to a GP before COVID. It's probably slightly easier now, actually, from my own experience. But, you know, could you explain the role of practice nurses and advanced nurse practitioners? Maybe others also?
One of the things that has helped with the telephone first thing has been about more triaging people to the right person. So, I mean, where I work now, we have several nurse practitioners. We've also got GP trainees and things like that. So people are being put in with as fairly appropriate as possible. So the GPs themselves are tending to see the really people with more complex issues and problems, whereas the nurse practitioners see people with sort of more acute problems, like I've got a sore knee, or, well, although they sometimes go straight to the physiotherapist for assessment, but somebody who's got you know, a possible infection in the finger might have a consultation with the nurse practitioner first, or with an earache or something like that. So they are actually being seen. So keep the appointments with the GPs more, as I say, for people with more complex issues and things, mental health problems and chronic disease problems and cancers and things like that. So for a lot of things, this is working better, because we were struggling a bit where, like, I would find my appointments as a GP were filled up with lots of people with coughs and sore knees and things like that, and then the nurse practitioner would be coming in to ask for help because she'd had somebody put in with her who had quite complex needs and things. So it's to a certain extent, this is actually working a little bit better for making sure people are seeing the right person in the surgery, basically.
Thanks, Elaine.
And I suppose you might also be seeing someone fairly regularly, say if it's for blood monitoring or blood pressure, if you've got another chronic condition. And I guess perhaps if you've got a concern, you can still bring it up with them and say, is this something you know I need to pass on to the GP? Because it surprises me sometimes how much practice nurses or ANPs might pick up and then bring to us, saying, I've been seeing Mr. or Mrs. such and such for weeks now, checking their blood pressure, checking their thing, and they mentioned this, and then they get streamlined back through to us, if that makes sense.
Thanks, Tom. I wonder if it's my own perseverance or whether it's because I'm a blood cancer patient. When I make that phone call in the morning, I tend to make a phone call after the rush hour, because it's, you know, I'm still working on old times when everybody used to phone up to make an appointment. I don't know if that's relevant anymore, because not everybody is actually rushing to the surgery, trying to get an in-person appointment. But when I make that triaging call, you know, to say I've got an issue or I want to be able to talk to somebody, I always get a timely phone call back from a GP themselves. I never seem to connect with any of the other services, and that might also be because I have, you know, there might just be minor issues. So do you red flag your blood cancer patients, you know, I suppose a lot of the times I'm phoning up, it would be for additional support with infections, you know, as an immune compromised patient. So I'm just wondering if that's the case, you know, if you deal with blood cancer patients differently than you do with the general, you know, not the general public, but the non-cancer patient public.
Yeah, we tend to have a much lower index of suspicion, and I mean, everywhere does something slightly different, but we certainly flag up blood cancer or immunocompromised patients, which may be through treatment as well, on our system, so that they get much quicker access, if that's the case, or quicker, or that's flagged up to the GP, who can then appropriately recontact or do whatever's needed, really.
Thanks, Tom. I'm just going to reiterate, you know, what an incredible service that I myself get, and it seems it's not being hampered by COVID at the moment. But yeah, sorry, Stephen.
Yeah, we just had a question come through as well, which you talked about the positive aspect of it, but see, some people are not necessarily have a good experience, or perhaps they've been dissatisfied with their diagnosis, particularly how this has been delivered, especially over the phone. So how will they kind of be able to give that feedback, or to kind of build that relationship with the GP? Elaine, perhaps you can give some experience of how people can kind of give that feedback, and maybe this is because it's more their experience that they've had with the hospital versus the GP, or sometimes people are in that position where the GP is saying kind of talk to the hematologist, and the hematologist is saying talk to the GP. But how can people kind of perhaps persevere with giving some of that feedback, or getting to the right person to get the right answer for that?
Yeah, I mean, it can be a little bit one where it depends, whose responsibility is it to do this, that, or the other. And I would say, I mean, I would find with a cancer, yes, the specialist will deal with their cancer and any queries and questions about that. But if it's on anything else, I mean, I think it was mentioned earlier about somebody who's got blood cancer, but menopausal symptoms as well. Now, I don't think their hematologist is going to be that interested in talking about their menopausal symptoms, or in my experience, that gets sent back to the GP and things. So as I say, it is sort of like, if it's to do directly with their cancer, probably it is the specialist, but otherwise it'll probably be the GP. And if in doubt, talk to the GP and see what they think.
Yes,
because I mean, I do sometimes say, ooh, not sure about this, and are you about to see or speak to your specialist? Because if they are actually going to be speaking to them 2 days time, then, and it'll wait 2 days, then I'll often suggest, well, I think you should bring this up with your specialist. But otherwise it might be, if they're not due to be reviewed for months, it might be me contacting them, their specialist, direct to ask.
Can I just chip in? I certainly, the hematologists look after, the hematologist looks after me, told me to regard her as my GP, and I should bring all new symptoms to her, and they would then defer back to the GP. I don't think that works particularly well. I think GPs are very good at being generalists and sorting out less, more obscure, less obvious problems. And I think there's a gap between the hospital and GPs. There's a sort of void into which a lot of symptoms will fall. That neither the GP or the specialist necessarily feel they have the skills to go into, as CLL is quite a complex condition, and for some GPs may feel quite scary places to be. But I think I would agree with you, Elaine, that I think go to your GP and talk about it rather than sit on it till the next time you go to the hospital, for example. Maybe she was just trying to make sure that I was going to respond with symptoms and not try and do it myself. I don't know.
Thanks,
and I think that's one of the challenges, just with kind of some of those symptoms, as you say, are quite vague, and there isn't necessarily a straightforward answer about it being one or the other. Again, we've had another one around kind of mental health issues and depression, and is there direct relationship between blood cancer or cancer in general and the depression, and how that I think it's worth recognizing that there is a challenge for GPs for sometimes to try and unpick some of these things as well. And as you've all said, actually it's about continuing that conversation, so that you can ask the questions to help actually distinguish between what might be one thing or the other, and then you've got that kind of in your toolkit ways that you can explore that in more detail. Is that fair to say?
GPs are very good at doing that sort of thing.
And I think just asking, as John and Elaine put out, asking your GP if they're not sure, then GPs are usually pretty good at flagging it up and saying, I think that might be something we need to deal with your specialist. And but likewise, there's sometimes a danger, I think, with specialists, that they may not be that clear on the intricacies of depression or anxiety, whereas your GP is probably managing that. You know, a third of our consultations have some mental health aspect to it, so that's almost bread and butter to GP. So it's really important that those things perhaps are brought up at the right person at the right time, really. So that's definitely one of the GP's roles.
Thanks. So just conscious of time as well, we've got about 4 minutes left. So that's been a really great discussion. Thanks very much for that. One of the things that'd be really interesting to see your opinions of, and thoughts are is, so we've had to do a lot of things in a lot of different ways quite rapidly, changing that as a result of COVID. But what do you see the future kind of hold? Do you see it kind of going back to the way it was, or are there things that we've learned and you've put into practice that we would like to see going forward, and how the GP will operate going into the future as well? Perhaps Tom, you can start with that first.
I think general practice will never be the same again now, and I think things will change or have changed dramatically, really. So I think the way people access general practice will be a mixture of telephone consultations, face-to-face, e-consults, video phone calls, and even much more use of text messaging, which we haven't really touched upon, but certainly that's been used a lot to communicate with people, to make sure they get the right slot for appointment, to say your results are ready, etc., etc. So that's been used much more. So I think there'll be much more of a hybrid system of that to come, and I do think that'll be better for patients and probably GPs as well, really, in that just there'll be a bit more of a mixture of different types of appointments, and I think that will improve access. So I think that's how it will be in the future.
And Elaine, your thoughts?
Yeah, no, much the same. As I say, I don't things won't go back to the way they were, and I think there are a lot of advantages for patients as well. You know, as I say, there's not every patient wants to make an actual face-to-face appointments and sit in the waiting room for ages, and things waiting to be seen. But obviously we have to be very aware as well of, like, it's okay for somebody that's quite tech savvy and has a smartphone and things like that, that it can be a lot easier when those that don't, or people that have got problems with their hearing particularly, it can be a big problem, and things. But then it's better for people who've got mobility problems if they can do a consultation from their own living room rather than having to get themselves into the surgery. So as I say, there's pros and cons, and it's probably, I suspect, we're going to need to we'll be able to keep have better recording of what problems people might have and what barriers there might be to things like video consulting or telephone consulting. I know now when I send a referral to the hospital, I make sure that I put, yes, this person's able to talk on the telephone about this, whereas or put, so this person's profoundly deaf and would really struggle with a telephone consultation and things. You know, and actually that sort of information is something we're going to need to make sure we're recording and things. So I also find sometimes people with anxiety and what have you struggle as well with telephone consultations. So it's going to be being quite aware of the fact that, you know, consulting remotely isn't going to suit everybody, and making sure that we do allow the access to face-to-face and things like that when appropriate circumstances.
Thanks. And John, from you, sorry, your experience as well, both as a GP and a patient.
Well, very quickly, I spend a lot of my life trying to promote telephone triage in my practice, and from my experience, probably about a third of the patients I saw could have been quite pre-COVID, obviously, quite adequately managed over the telephone. But at the end of the day, I think face-to-face is the gold standard, and I think a lot can be obtained by the GP, by the doctor from that, but also therapeutically given back to the patient as a result of that. And I do miss my face-to-face contacts as a GP now.
Thank you. So I think that's all we've got time for, as they say, so we'll draw that to a close. Thank you, yes. So we just wanted to share with you, both from the Leukemia Care and Lymphoma Action, we've Obviously, no, thanks very much for all of the questions you put through. We weren't able to answer all of them, but I think we've got a good overview of the experiences right now, and also from a good experience from our GPs and from our panel. So thank you very much for that. Just wanted to touch on that the services available both from Leukaemia Care and Lymphoma Action. So we're running a number of webinars and videos like this. We have information and on both of our websites, and you can sign up for the respective magazines and to receive that information, etc. And next slide. Then so we both have telephone and email, WhatsApp live chat support that you can have. You've probably experienced some of the virtual support groups that both of us have run instead of the usual face-to-face support groups, online buddy schemes. And I think a couple of questions touched on the kind of support that people can get post-treatment. Not only can you get that directly back from GPs, again, having that conversation, but from some of the educational workshops that we both work with to do that. Anything else to add, Nick, from a Leukaemia Care point of view?
I think you've covered that pretty well. Other than from a webinars point of view, is obviously keep focused on the websites. We've got plenty booked for January, and I know we haven't touched on COVID at the moment and vaccinations, but obviously these are being rolled out by. Obviously, the contact details are here for the website, and if you want to get in touch with advocacy services. But in other blood cancer groups, as well as Leukaemia Care, Lymphoma Action, are here on this slide. Are also will be rolling out webinars to keep the community posted of the COVID vaccine situation, which we're all very hungry for the information on. And really, I'd like to just obviously take the opportunity to wish everybody who's joined us a very Merry Christmas and a Happy New Year. And special thanks to our panel after a very busy day in joining us today to support the community. And as mentioned earlier, sorry, I jumped the slide. I obviously hadn't said that we have our upcoming webinar on COVID vaccinations, which will be coming immediately after the seasonal break. I think by that time, there'll be a lot more information fully available and the rollout will be fully underway. But in the interim, there will be a few others being provided by the other blood cancer groups. So just keep posted and we'll keep you informed through our own comms channels. Stephen?
Yeah, so thank you. So thank you to Elaine, to Tom, and to John as well. And have a good evening. Thanks very much.
Everybody.
Thanks very much.